Hello, everyone, and welcome back to another lecture coming live from the top right corner of the screen today. This is our last lecture of the semester, and we'll be talking about COPD. For most of this class, we've briefly talked about some diseases and pathologies that occur, but today we'll be talking about chronic obstructive pulmonary disease, what that is, and what changes when people develop COPD. So here below you see the learning objectives. We will probably split them up as I have been doing usually into two separate videos. But the key question today, what is COPD? What structural damages occur in the lungs with COPD? And how do these structural damages to the lung affect normal pulmonary physiology? Some key terms. So again, if you just want to stop the video and read these over, so this way as I am going through, you know the terms I am talking about, that will be good. But just to overview, with COPD, it is a pulmonary disease, and this gives people a difficult time breathing. So a lot of times there is abnormal or difficult or strenuous breathing. So we'll be talking about a lot of that today. And so that's called dyspnea, which is the difficult breathing, and tachypnea, which is abnormal or rapid breathing. All right, so as we know, chronic obstructive pulmonary disease is present in a lot of those who smoke. So first, what is a obstructive disease, and how does that differ from a restrictive disease? And so depending on what type of disease you have, it can impact your lung volumes in different ways. And so a restrictive disease typically will impact your total lung capacity, and that's when you take a max inhale, that's when your lung is completely full, and that's called your total lung capacity. Well, in a restrictive disease, such as pulmonary fibrosis, you're going to have a lesser total lung capacity. Actually going on right now with coronavirus, a side effect of some severe cases is that there's this pulmonary fibrosis, that some of that lung tissue is actually being destroyed and replaced with less elastic collagen. And so this would limit how much you could fill up your lungs with air. And so that happens in a restrictive disease, while an obstructive disease limits the amount of air that you can expire due to air trapping and reduced pathways of the airflow. And so that obstructive disease is when you see an increase in your residual volume. So when after you do a max inhale, the amount of air left over, with COPD, you're going to see more in a person after they exhale, because that air is trapped. And this is going to be a negative thing because that air basically becomes stale, right? It's not taking part in that exchange when we inhale and exhale, bringing in that new oxygen and bringing that oxygen into the lungs. So some of that air gets trapped, and it restricts our blood oxygen and our carbon dioxide as well. So again, main point, restrictive disease impacts your inspiration and your total lung capacity. Obstructive diseases impact your expiration, and you see an increase in residual volume. So there are many underlying conditions that can cause COPD, but the number one cause of chronic obstructive pulmonary disease is going to be cigarette smoking. And that's why, as health professionals, it should be one of our top priorities to get clients or patients to stop smoking, because it just causes a lot of damage in our lungs and can lead to poor quality of life as we get older. So, trying to get people to stop smoking, at minimum, trying to get them to cut down on the number of cigarettes they smoke, because this is the number one factor for COPD, and it can lead to major complications as you get older, as we will see. There is potential for genetic disposition, although it's definitely a smaller fraction than compared to cigarette smoking. And then external environment, such as pollution and the environment that you work in. So let's say like a coal miner or something like that. If the air is polluted around you, whether it be just walking on the street and a lot of major metropolises around the world now, they have many problems with pollution, which is comparable to the cigarette smoking. So even if you don't smoke, if you live in an environment where the air is heavily polluted, it can cause COPD. Or again, even at work. So, we want to try to limit all of these things to try to limit the likelihood of someone developing COPD. One of the most pronounced features of COPD is the overinflation of the lungs. Whether you call it overinflation or hyperinflation is the same thing. Here we see an example of that. Looking at an X-ray here, this is a normal lung shape here to the left. You can see down below the diaphragm, it's normal curved shape there, the dome-shaped diaphragm. And then you see with a COPD, you get this air trapping, this lung overinflation. And again, this isn't a good thing. When we think about something like exercise, we think, oh, we get more air into the lungs, so that means more oxygen, and we get rid of more carbon dioxide. But in this case, this air is trapped. So again, it sort of becomes stale. It doesn't really become, that increase in air within our lungs, that increase in residual volume isn't helping to contribute when it comes to the, increase in oxygen or getting rid of carbon dioxide. So COPD has negative consequences here because of this hyperinflation. In addition to the hyperinflation of the lungs, we also see damage to the alveolar space. When you get damage to the alveoli, what's going to happen is you get less area that can take part of diffusion, and that's going to have a negative impact on our blood gases. And then also, when these alveoli become destroyed, air can sometimes pass through in areas where it's not supposed to be, like the intrapleural space, which can cause airway compression, which is very negative as far as breathing is concerned. In addition, because of the constant state of inflammation due to the damage with COPD, we are going to have enlarged mucus glands. And we remember from previous lectures that mucus is not an ally when it comes to the diffusion of blood gases. It makes the alveolar wall thicker, that space that that oxygen or blood gases have to diffuse. It makes it thicker, and then you don't have as much diffusion. So all these things, hyperinflation, destruction of the alveoli, increased mucus production, all negative things when it comes to the exchange of oxygen and carbon dioxide. So physical limitation is airway obstruction. And the reason why airways are being obstructed with COPD is because they are reduced in the cross-sectional diameter. And if you recall from our lessons about blood, we know that when a vessel decreases its radius, this increases resistance and decreases blood flow. The same thing is true for airways. So with COPD, when you get this reduced cross-sectional area of the airways, that's going to increase resistance and decrease air flow. And so you have these structural changes to the airway, which then result in decreases in air flow and increases in airway resistance. And then, you have these airway abnormalities are going to get worse as the disease progresses. And then, once you excel to the later stages of COPD, you're going to get severe air trapping and lung hyperinflation. And that's going to limit, of course, how much air that we can get out, but then that in turn has an effect with how much oxygen that we can get in. Because if air is being trapped within our lungs, we can't replace some of that old air with new air to further oxygenate our alveoli. And this is a big problem. So here we see an overview of what happens with COPD. You have this airway obstruction, which results in the air being trapped and the lungs hyperinflating. Because the lungs are hyperinflated, your lungs have to try to, well, really, your respiratory muscles have to work harder in order to get in the same amount of air, which results in difficulty breathing. And then, sometimes if you feel like I can't breathe, that brings on anxiety, which brings on rapid abnormal breathing, which sort of accentuates all of this. And then, you can't, because of this disease, you can't be as physically active. And then because of that, your respiratory muscles and your conditioning overall, uh, will lessen. And then, this then requires you to work harder at rest. So it's just this vicious cycle that COPD does to a person that results in a poor quality of life because this person cannot get the oxygen demands that they need, and so they have to work harder in order to get that oxygen, and that makes a person feel very fatigued. And once they get into that zone, then they can't even improve their health through exercise. And so that's when the condition gets worse and worse and worse. So if we can prevent this from ever occurring, if we could try to limit the pollution, if we could try to limit the cigarette smoking, if we could try to get people to exercise and participate in cardiovascular activity, well, then we're going to have less likelihood of COPD and less chances of the patient having to deal with all these things. And so this is how COPD progresses. First, there's a non-uniform narrowing of the airways. So some of these, bronchioles will get smaller, and then that'll increase resistance to airflow. And because of that, then there's an uneven distribution of air coming into the lungs. And then in addition, there is a loss of elastic recoil, right? So we have these lungs that are able to expand and take in large quantities of air and then recoil and then exhale some of that air. But then when you lose some of that elasticity, you're going to have less air flowing in and out of the space, which is going to affect your lung volumes. And what's that going to result in? Well, it results in air trapping. So you're going to get this increase in residual volume at the end of exhale. And then what's that going to do? Since you have more air trapped in your lungs after an exhale, well, it's going to push down on the diaphragm, right? It's going to push it down, and it's going to, as we'll see in a second, change the shape, our normal shape of our diaphragm, which is going to lead to an increased work of breathing. So we're going to have a hard time getting air in and out, and that's what's going to make it uncomfortable for the patient with COPD. There are two separate subclasses of COPD. One of the diseases is called emphysema, and here we can see the lung. And if we zoom in, we see what normal healthy alveoli look like, and right under where it says number 1. And then number 2, these are alveoli with emphysema. And so what's going on here is we're getting small airway destruction. We're getting destruction to the alveoli and the alveolar ducts because of damage, and this leads to chronic inflammation. And so what's going to result of this is that we're going to get a loss of lung elasticity, which is not going to be good for our respiratory volumes. And then we get thickening of this vascular wall, which we know is not good for the diffusion of blood gases. As those alveolar walls become thicker, it gets harder and harder for oxygen and carbon dioxide to transport. And so this increases the difficulty of breathing, and the body tries to compensate since it can't get out as much air with every single breath, that it tries to speed up the rate of breathing, which can cause fatigue to respiratory muscles if severe enough. And so how we characterize this again is called pink puffers. So these alveoli, when they become inflamed, when the walls become thicker, that is what we see. And so those are called the pink puffers, and that does differentiate emphysema from the other subtype of COPD, which is called chronic bronchitis. And so in chronic bronchitis, instead of the small airways being really damaged and inflamed. It is the large airways that are becoming damaged. And here we see to the right where we have a normal bronchial tube here where this air is normally going to come in through the lumen here, and then one that is inflamed. So whether it be due to smoking or pollution causing damage, you're going to get that inflammation response, and that's going to lead to swelling. So there is an increase in resistance to this air pathway since the air diameter has decreased. And we also get an increase in mucus production, which also increases resistance as well. And so while emphysema is characterized by pink puffers, chronic bronchitis will be characterized by something called blue bloaters, which you get cyanosis, basically a bluish tint to some areas of the body due to the fact that there is lower oxygen. So of course this is not a good thing. This means that our oxygen levels in our blood are depressed and totally awful when it comes to the normal functioning of our cardiopulmonary system. Normally, our diaphragm is dome shaped. So as you see in the resting position right here, the diaphragm presses up against the lungs, and so at the end of our expiration, that diaphragm is completely relaxed and the lung volume is smaller and the pressure inside is greater. And so as we begin the inspiration, that diaphragm contracts. And here we see through its range of motion that it's going to contract downward, and this expands the chest cavity and expands the lung volume. And what happens is our pressures inside of the lung become lesser. And that's how air gets into our lungs. But with COPD, what we're going to see, since we have that air trapping and hyperinflation of the lungs, is that the diaphragm is not going to have its normal shape. Instead of the domed, curved shape that we normally see, we're going to have a flatter diaphragm. And what this does is that it limits its range of motion. So it's not able to change the lung volumes and therefore change the lung pressures as dramatically. And so, just like the other skeletal muscles that we use during exercise, in order to produce a lot of force, you don't want to limit the range of motion. Think about when you do, your major lifts, your squats, your bench press, things like that. You go through your full range of motion to get as much strength as you need out of those muscles. And so the diaphragm, although maybe not the same comparably as far as forces are concerned, it does need that range of motion in order to change these lung volumes more dramatically. And so when this diaphragm is flatter and has less of a range of motion, we're going to see more shallower breathing. And that's going to lead to a lack of O2 transport, which is overall very, very negative for our pulmonary system. And so we have higher lung volumes in certain cases when we think about residual volume, right? And the amount of air left over after exhaling. We are going to see that yes, these air volumes after we exhale are increased, but this is not a good thing because what this does, this hyperinflation does, it increases the amount of work that we have to do in order to get in O2 because we're now working against this stale air, this air that's not going to escape, in order to get in more oxygen. And since the diaphragm in COPD is low and flat, it decreases our mechanical efficiency. It doesn't work as well changing those volumes and changing those pressures within. And so since we have this increase in ventilatory work, since now instead of, less times per minute, the diaphragm having to contract, well, now that it's lost some of its efficiency, it has to increase the rate of respiration. The body has to increase the respiratory rate, which means that the requirement, because now we're working more often and, how much energy those respiratory muscles are producing, have now increased. So they're working harder for less oxygen. And this can equal ventilatory muscle fatigue in those with COPD, which is why once you get COPD, it's very hard to basically live and try to make better, because with exercise, it's going to be harder for these individuals to take in that air. And so they can fatigue easier and therefore may not get all the benefits out of exercise that they potentially could without COPD. So what we are going to see due to this hyperinflation is two things. We get changes in our lung volumes, right? So the amount of air that we can exhale decreases. So when we think about tidal volume and expiratory reserve volume and vital capacity, those are all going to decrease. And so when we think about the amount of air left over in our lungs, the volume of air in our lungs after expiration, whether it be a normal expiration or a max exhalation, so that's going to be either functional residual capacity or residual volume, those are going to increase since more of that air is getting trapped. And since that air is getting trapped, and we need to then work against it in order to try to get in more air with more oxygen, our body increases respiratory rate and minute ventilation. So those respiratory muscles, they have to work now more often, which, as we discussed in the last slide, can lead to fatigue. And because of this increase in respiratory rate, sometimes we see a further increase in lung volumes. So how are we able to measure all of this? We do it through a process called spirometry. We'll show a picture back in the day, but you used to be able to just have an old school machine which hooked up a tube to, it went through some air, and then you had a pencil. So with every exhale and inhale, it would chart it out on the graph what that person was doing as far as tidal volume and inspiratory reserve volume. But this is how we're able to determine, how someone is doing or how someone is progressing with COPD. And then we could also look at things like difficulty breathing, their exercise capacity, and quality of life when it comes to COPD, to seeing how they are progressing. And so we've listed most of these, but negative impacts of lung hyperinflation is that we're going to have a decreased elasticity of the lungs, difficulty breathing because we are working harder in order to breathe. It's more laborious, and so this can obviously impact exercise and our capacity for exercise. And another thing that also happens because of it is that we see a decrease in venous return and cardiac output as well. So here's an example of spirometry, and here's how it used to be done in the day before we had a lot more advanced technology. So you hook up a tube to the spirometer, and then as the person inhales and exhales, you're able to see these differences in tidal volume, vital capacity, and total lung capacity. And so a major complication and something that we see with COPD is airway compression. And so since we have a harder time expiring out air, a lot of times when we get this airway compression, where the intrapleural space becomes greater than the alveoli, and that could lead to actual lung collapsing, which is not good. See, normally, as we know, that transpulmonary pressure, the pressure difference between the intrapleural space and the alveoli, is always supposed to be negative, meaning that even during an exhale, that intrapleural space is always less than the alveoli. Well, in COPD, because the air cannot get out as well to the same degree, this can build up pressures during a forced exhalation and then cause the collapse of the lung for someone with COPD, which is very dangerous. So here we see, as someone is breathing out, we have 3 individuals. A would be a normal individual, or a healthy individual, I should say. C would be a person with a restrictive disease, and then B would be a person with COPD or an obstructive disease. So in A, right, so from our total lung capacity, someone is able to exhale large quantities of air within that first second, and then progressively let out that air all the way till a max exhale. While in a person with a restrictive disease, they're still able to get out a large quantity of air within that first minute, although it is less than a person who is healthy in their lungs. And then you could see the person with an obstructive disease not getting out a lot of air within that first second, and then progressively, not able to exhale large quantities of air. And so this is going to limit our ventilation at rest and during exercise. And so I bring up this 1 second point because it is what we use a lot of times to determine how far someone has progressed with COPD. And so we'll talk about lung volumes in a moment on these next couple of pages. But let me skip forward for a second. Two major indicators that we use are this FEV1, which is the forced expiratory volume in 1 second. So what you do is you'll have a person inhale deep, get to their total lung capacity, and then they'll exhale as forcefully as you can. You may have done it before when you were younger and gone to the doctor to see how your lung health was doing and how your pulmonary health was. And so that entire exhale from total lung capacity to residual volume, when you force it, that's called forced vital capacity. So it's the same as vital capacity going from a max inhale to a max exhale. So now you're just forcing it out as powerful and as quickly as you can. And so the total amount of air that you exhale is called that forced vital capacity. But that amount of air that you get out in 1 second, that's called your forced expiratory volume 1, or FEV1. And so as we see here, that FEV1 is going to be a lot less in those with an obstructive disease compared to those who are healthy or even with a restrictive disease. All right, so now just knowing pulmonary volumes and capacities and know which ones are going to change with COPD. So here we see some of those volumes and capacities. And so when you see below, when you see predicted, this is what a normal individual of this person's size should be measuring at. And then observed are going to be those with COPD. So for vital capacity, which again is the max amount of air that we can exhale after a max inhalation, predicted that would be 4.8 liters. Here, in the person with COPD, 3.3. So vital capacity decreases. The amount of air that we can exhale after a max inhale would decrease. Functional residual capacity, remember, that is the amount of air in our lungs after a normal exhalation. And since, normally that's going to be a 3.7, well, since we have air trapping in COPD, we are going to see that that volume, the amount of air after a normal exhale, that increases. Total lung capacity, that's going to increase as well. And so don't be fooled, though, that this isn't a good thing. Again, just because the lung volume has increased doesn't mean that our flow of oxygen and CO2 has increased. And so that's an example here of, okay, well, the amount of air in the lungs overall, it's hyperinflated, but that's not really going to help aid us too much as far as the flow of blood gases are concerned. And then we see also compliance, the volume of air that comes within the lungs, it increases. But again, not a healthy measurement. Doesn't mean that this total compliance increase is all the way positive, because it's not. And so down below, you can see, again, FEV1 and forced vital capacity. These will both decrease in patients with COPD. And not only that, when we take the ratio of FEV1 to forced vital capacity, or the volume of air you could get out in 1 second compared to the total, that decreases dramatically. And so here we see the differences in those who are healthy, in those with COPD, and those with a more restrictive disease. So with COPD, we get a reduction in both FEV1 and forced vital capacity. We would see the same in a restrictive disease, but we would see that ratio be relatively the same, where a person is able to get out most of their forced vital capacity within that first second. The difference is that in an obstructive disease, that ratio is going to become a whole lot less, and this can lead to complications, obviously, both at rest and during exercise. So here you see major differences here in FEV1, forced vital capacity, and that ratio. And so this is how we are basically able to track how far someone has progressed with COPD. And so we use the gold standard for that. And so that provides the framework and what stage a person with COPD is. It goes from stage 1, which is considered mild, all the way to stage 4, which is considered very severe. And so how you measure what stage of COPD someone is at is, one, by taking their FEV1 to forced vital capacity ratio. In a person with COPD across the board, that is going to be less than 70. Normally, that ratio should be around 80. And so that's going to be the same for all 3 stages. But then as you look at what does separate each distinct stage, is going to be just the FEV1. So in stage 1, it's still above 80. Stage 2, between 50% and 80%. Stage 3, between 30 and 50%. And then stage 4 will be below 30% or less than 50 plus chronic ventilatory failure. And so, this is going to, obviously, the worse this progresses, the worse it's going to be as far as quality of life, the difficulty breathing, exercise capacity, and COPD is non-reversible. So once you get into a stage of COPD, you can only maintain. And so even with exercise intervention, it's going to be very hard for this person to improve quality of the life. So, what we try to do is, if a person does develop COPD stage 1, that we try to introduce either drugs or therapies in order to try and keep them there and try to progress from there and try to better their quality of life once they develop. But you are going to manage these at different stages. So stage 1, more than likely, you're just going to prescribe more exercise to the individual, try to get them to cut down on their negative behaviors, cut down on smoking, stay out of polluted environments. Once we get to stage 2, we would probably administer a bronchodilator to open up some of those airways and probably practice some breathing exercises. As you get to stage 3, a glucocorticosteroid, in order to help with breathing. And then as it gets more and more severe, you may actually be administered with oxygen therapy, right? So actually getting hooked up to an oxygen tank in order to help you breathe. Because at this point, what has happened is you have this decreased ability to get air in and out of your lungs, and your blood oxygen levels are now so low that we need to saturate your lungs with oxygen in order for you to get an ample amount. And so this will close part 1 of COPD. In the next lecture, we will talk more about COPD and the different pressures and compliances that are occurring with COPD. But for this video, just make sure, again, you understand what the consequences are of COPD and what are the things that are occurring. So you're going to get this damage to the lungs because of smoking or pollution. That's going to result in airway destruction and hyperinflation. And then this hyperinflation is going to affect the amount of air that we can exhale. So more that air gets trapped, and the problem gets progressively worse. Thank you guys so much, and I'll see you next lecture.